Discover the latest health tips, expert advice, and inspiring stories. This is the Health Channel Podcast. Your journey to better health starts now.
We always give great information here on Ask the Doc. But for this episode, let's feel free and dig a little deeper. We're here to answer your spine and back questions. Prepare to go full Brusovanik today because I got your back. On this episode of Ask the Doc, no appointments needed. Welcome to Ask the Doc, the show where we encourage our viewers to send in their health questions. I'm Dr. Georgiy Brusovanik, a minimally invasive spine surgeon. Let's start things off with a Facebook question from Anthony, who asks, "Hey, Dr. Bru, I know you're a minimally invasive spine surgeon, but what does that mean exactly? Like, are there maximally invasive surgeons out there?" Hi, Anthony. I can't tell you how much I love this question. So what's minimally invasive spine surgery from my standpoint? And are there maximally invasive spine surgeons? Anthony, a minimally invasive approach is a multifaceted approach. In other words, minimally invasive describes an entire view of surgery where you try to minimize the trauma to the patient. Now, think about it. As you saw in this video, your spine and the discs, they're deep in the center of your body. So to get to your spine and to still be able to see well, used to require a big hole. And what we refer to as classic spine surgery is sort of maximally invasive. Structures that are in the way get mobilized and removed possibly, and this allows a spine surgeon to get to your spine to correct the problem. Now, obviously, there's more trauma when there's injury to a lot of structures and root to your spine. Now, compare that to a minimally invasive approach, which utilizes more advanced technology to allow a surgeon like myself to do a more sparing job. Very simple. So instead of making a big hole in your back, I make a small incision on your side. I use a tube. That tube gains me access to your spine, and I'm able to correct the problems such as remove a disc herniation, perform a disc replacement, or fuse a painful deformed segment through that same hole, through that same tube. Now, once the tube is withdrawn, there is very little bleeding, and the muscle heals fairly quickly from the trauma of putting in that tube, as compared to taking the muscle off the bone, traumatizing the tissues significantly more. Now, there are other angles to this. For example, navigation is part of minimally invasive technology, and that allows a spine surgeon like myself to use a CAT scan that is obtained during surgery to then guide the placement of instrumentation into the spine. There's also usage of a microscope, an extremely strong light, and x-rays during surgery that allow me to know exactly where I am, that allow me to know exactly what I'm doing, but without creating a big traumatic hole. Thank you for this question, Anthony. I hope this answers it. Our next question comes to us from Tatiana, who reached out to us on our YouTube page. "Hi, doctor. I've grown up with scoliosis, and I guess it's severe enough now where they want to perform surgery on my back. Unfortunately, they are going to be doing open surgery, and I want to know why I'm not a candidate for minimally invasive surgery." Tatiana, that's a great question. So there's definitely a way to perform scoliosis surgery via a minimally invasive approach. Now, in some patients who have a curve since they were little kids, a curve that only got worse as they got older, an operation may require fusing or knitting together bones over 15 or 20 segments. Now, if that's the case, it isn't practical to address each segment through a placement of the tube because of the amount of time that it would take and the danger of having such prolonged anesthesia. So theoretically, an argument can be made in that rare scenario that a classic open operation that destabilizes the spine and then a surgeon places screws, and then screws allow a rotational maneuver to get rid of that scoliosis. That may be a better option, but honestly, I've never seen that situation. In my experience, if a surgeon does minimally invasive spine surgery, then they will only offer minimally invasive spine surgery. As opposed to somebody who does the classic technique, they will likely stick to their old technique. But I have a better answer for you. Get a second opinion, Tatiana. Especially if you're considering such major life-altering surgery, it's always a good idea to get a second opinion. Thank you for your question. Drake reached out to us on our YouTube page, and his question for me is, Dr. Brusovanik, I have a herniated disc in my lumbar region, and my doctor has suggested a steroidal injection. So my question is this: what are steroids exactly, and can they fix the problem? Hi, Drake. You actually asked two questions, so here's the deal on the steroids. So steroids are the world's greatest anti-inflammatory. In fact, those medications we get over the counter, like aspirin, Advil, ibuprofen, are commonly referred to as non-steroidals versus a steroid pack, which is a 6-day course, IV steroids, which are delivered through a vein while you're in a hospital, or the most precise, which are steroidal injections that aim to deliver the medicine right behind the painful disc, the red inflamed disc. So do steroids actually change the problem? Do they fix the problem? Or do steroids mask the problem? Well, the answer is actually somewhere in between, and I'm going to give you a perfect allegory to understand what's going on. A disc degenerates, little waves of inflammation come and go. Some of those waves are associated with pain. We want to get rid of that redness. That redness is not different than the redness you may get in your eye if you get on the motorcycle without goggles. So imagine you got off that motorcycle, you looked in the mirror, and your eyes are red. And then you take some liquids like Clear Eyes and you put that into your eyes. And now the redness is gone. Now imagine 6 months go by, a year goes by, and you don't get back on the motorcycle. Are the drops still working? And I think you'd clearly agree that the drops are already far gone. They've already disappeared from your body. So have those steroid injections. So how can it be that an injection worked for a year or 2 years? Well, the answer is the inflammatory pathology did not come back. Either your body was able to ignore the inflammatory issues or ignore the degenerative changes without mounting an inflammatory response, or the problem just went away and the disc is no longer an issue. So for those patients who say that they got a year, 2, 5 years out of an injection, I hope you understand that what that means is that your body did not produce more inflammation. The steroids were gone from your body after just 2 or 3 days. I hope this answers your question because it's a difficult question. Steroids don't truly reverse disc degeneration. Steroids do not cure you from degenerative disc disease, but steroids also do not mask the problem. This isn't like morphine or lidocaine, so steroids actually take care of that redness, and they help a lot of my patients to avoid surgery. That's a great question, Drake. Thank you. Zion sent in this question via our very own website, allhealthtv.com. Zion asks, hey, Dr. B, I've had a couple of steroid injections, and I'll be honest with you, they haven't lasted that long. Only a couple of weeks each time. Why is that, and what should I do next? Hi, Zion. This is a really important question, and I appreciate you sharing your story with us. So, building on what we just discussed, steroids relieve inflammation. And in your question lies the key to the answer. Your injections worked. Now, they only worked for a few weeks, but placement of that injection behind the correct disc, and only behind the correct disc, can yield back pain relief. So you have proven to yourself and to your docs exactly where the pain is coming from. Now it's reasonable to correct the problem. It's reasonable to consider surgery because a good outcome should not be a surprise. A good outcome should be as good as guaranteed when the right disc is going to be operated on, and if that disc is correctly fixed, replaced, or removed. So, what do you do next? You need to go back to your doc and make sure you make it very clear that for a few weeks, the injections took away your pain. I think your doc will see it the same way as I have, in that you are now a fixable person, a person with a fixable problem based on that early response with your injections. And if you can't live with your pain, it's reasonable to consider fixing it. Thank you for that question, Zion. This next question comes to us from Aubrey, who asks, Dr. Brusovanik, I have degenerative disc disease, and my doctor is suggesting physical therapy. How effective is it, and can it really help prevent surgery? Hi, Aubrey. It seems like all our viewers are sneaking in an extra question or two. No worries. We love your proactivity, and I'm going to answer every question. So, can physical therapy help? Is it effective, and can it prevent surgery? So, the short answer is yes. Physical therapy is effective, and it can prevent surgery. But it's very important to be specific with which problem and which surgery. For example, if someone has a degenerative disc and they have severe back pain, a therapist may help you strengthen your core, or really what that means simply is strengthen your abs. And if you are persistent with the exercises, you may find that your back pain is a lot less bothersome, and the episodes of dysfunction or muscular pain as related to the disc problem are shorter and less painful. Now, if someone has a fracture that has left that patient in a forward flexed posture, physical therapy may help these patients to reposition their posture into a more favorable sort of alignment and allow you to have less back pain. Again, something very helpful, and can help these patients to avoid surgery. Somebody with stenosis or narrowing in the canal may find that their legs are not listening to them and they have a difficult time walking. Physical therapy may help you with some tricks like a cane or where to place your hands. It may help you walk upright despite your dysfunction. That being said, physical therapy is not a panacea, so physical therapy has no room for patients who have sciatica or nerve pain going down their legs or going down their arms. Physical therapy cannot help you when you can't walk or you can't exercise because of severe back pain. Physical therapy cannot help you with severe neck pain that's associated with pain under the shoulder blade or pain going down to the arm. So it's important to find an ethical therapist who is well-versed in what he can and cannot accomplish. So just like my redundant advice, get a second opinion with your docs. If you feel like the therapy that you're doing again and again and again is not yielding any good outcome and is possibly even hurting you, I would stop immediately and seek a second opinion from another physical therapist. I hope this helps. Next up, we've got another question from allhealthtv.com. You should really check out our site when you get a chance. It's chock full of great information. This next one is from Nico. Nico asks, hey doc, can you help settle a bet? My friend thinks there's a difference between a bulging and a herniated disc, and I'm pretty sure they're the same exact thing. Who is right? I would really like to know what that bet was for. But I'm going to answer you anyway. So there's a classification to disc degeneration. And in the world of radiologists or doctors who read MRIs, everything that's abnormal when it comes to a disc is a herniated disc. And that includes a disc that's bulging slightly, a disc that's actually come out of place, a disc that tore and allowed a big part of it to enter the canal and compress a nerve. All that is considered to be a disc herniation. So from that classification standpoint, the bulging disc is just the beginning of a degenerative process. Unfortunately, within that classification, everything is a herniation. Now, when you talk to a spine surgeon, they'll tell you something different. They'll say that a herniated disc and a bulging disc are not the same thing, in that a bulging disc is more associated with disc degeneration, loss of disc height, and widening as what commonly occurs with discs that are degenerating, versus a disc herniation to a common spine surgeon is something very specific, a process where a disc ruptures and the inner part, the nucleus, sneaks into the canal. The reason why there's such a difference is that they're treated differently. A bulging disc is something that often requires a disc replacement when the patient cannot tolerate the pain, versus a herniated disc most often deserves a discectomy, or an operation where a surgeon will sneak into the canal and remove just a piece of the nucleus of the disc that snuck into the canal. I really hope this answers your question, Nico. This next question comes to us from YouTube, from Astrid. Hello, Dr. Brusovanik. So what's the deal with artificial disc replacement? What are they made of? And is it one size fits all? Okay, great question. Astrid, artificial discs were invented about 30 years ago, even 40. And now we have a great testament of time and research to support replacements. Insurance companies are now approving disc replacements. And we have great studies that show that outcomes are much better in that you avoid problems at other levels if you avoid a fusion. And the way to avoid a fusion is with a disc replacement. So there's a lot of modularity to these discs. In other words, before I start the operation, there are about 10 boxes of varied parts that allow me to dial in the proper alignment, proper height, width, depth, as well as height of each prosthesis. So you can really tailor the prosthesis to the patient. So they're not one size fits all. And I'll tell you this, as a recipient of a disc replacement, actually of 2 disc replacements in my lower back, I firmly stand behind this technology. And I would advise anyone who has severe back pain or neck pain, who is talking to a surgeon who's saying that they can't live like this, to consider asking your surgeon about maintaining motion and performing a minimally invasive disc replacement. Thank you again for this question, Astrid. Luca just sent us another question on YouTube. Luca asks, Dr. Brusovanik, I went to a chiropractor to help me with some back pain I was having, so he did the usual back cracking stuff. What's the purpose of what they're doing, and what makes that horrific noise? FYI, it didn't really help me, by the way. Hey, Luca, great question. And I'm sorry you didn't benefit from the therapy. So the noises can come from 2 sources. Either it's tendons snapping over bony prominences, as you would imagine in your hip, or soft tissues inside the joint with a negative concavity compression creates a pressure, suction effect. And then once a joint is moved, that suction opens and releases a bit of nitrogen, which makes that sound. Now, the other part of your question, what's the purpose of what they're doing? I really don't know. There are some studies that manipulation may help with acute back spasm. But a lot of patients who come to see me say that the manipulations help temporarily, and when they leave the office, they usually feel their pain coming back. There's some good research behind chiropractic manipulations. And in good hands, with somebody that has an ethical, reasonable view of spinal pathology, who won't do something dangerous like crack your back in the face of a disc herniation or stenosis, narrowing of the canal. Chiropractic manipulation is generally safe. There have been some issues with vertebral artery injuries in your neck from aggressive manipulations, but I guess like with anything else, chiropractic care comes with some risks. Now, I believe that chiropractic care is well-meaning and well-intentioned, well-indicated for cases of non-specific low back pain, acute low back pain. But if you're having chronic back pain, if you can't sit for too long, if you have to keep fidgeting at the dinner table, if you can't stand for too long, and if once you stand up, you warm up and you feel better. So in other words, a classic presentation of a degenerative disc. Chiropractic care may not be as helpful, and if you feel after 1 or 2 sessions that it's not helping you, I would stop and get a second opinion. Thank you for this question, Luca. Our next spine-related question comes to us from Skylar, who reached out via Facebook. Hi, Dr. Brusovanik. When a patient comes in with back pain, how do you determine whether it's coming from a disc issue or from the surrounding muscles? Okay, that's a great question, Skylar. Thank you. So most back pain and most neck pain is muscle pain. But why? Why would you have muscle pain? Well, if you came to me after spending the day moving furniture and you said you have back pain, I would likely say that it's probably related, especially if your back pain began while moving the furniture. And I would expect that pain or muscular pain to get better on its own. But now imagine a scenario where back pain comes and goes, or where back pain begins after you sneeze or try to pick up a piece of paper or a cat, something light. So those scenarios underline the fact that most of chronic back pain is muscular only in eventuality. It begins with a culprit. It begins with a fire that burns in the back of a disc. That disc is irritating a nerve or local soft tissues. And then your body does what it does best. It self-splints. If you hurt your elbow, you will find that the range of motion decreases. The joint may still be okay, but your body doesn't want you to move a painful part. And especially if that painful part is a disc, which is a very much weight-bearing structure that begins to touch a nerve and cause sciatica or pain going down the arm, down the leg. In those scenarios, it becomes obvious that there's a neurological component, as only nerves can cause pain going up and down your extremities. But why are the muscles hurting? Well, your body is self-splinting. So it's very important for us to really understand why the pain is there. And not only so that we don't catastrophize and we take it for what it is, as in something that's not dangerous or scary, usually, but also so that the treatments are more addressing the issue and not some nebulous protocol. For example, if you come in with difficulty sitting and standing and pain going down the back of your thigh, your doctor should not be offering you a facet joint injection or an injection that addresses the pain from the joints in the back of the spine. That doctor should be addressing the disc nerve interface, or where that disc is pushing on the nerve that's causing sciatica. That being said, those patients who complain of severe stiffness after playing golf usually have a problem with the facet joint. About 20% of back pain, in my experience, comes from the joints in the back of the spine, and those patients deserve an injection around the facet joint. So I appreciate this question, Skylar, and it's very important that the audience understands that if your doctor is not addressing these questions, if when you ask, why am I hurting, you don't get a clear answer, please get a second opinion. I hope this helps. Our next question comes from Esme on allhealthtv.com. Dr. Brusovanik, are there different types of physical therapy for various back issues? I love this question, Esme. Absolutely. So I'm not really well versed in the types of physical therapy maneuvers. I can tell you that there are some well-known eponymous physical therapy approaches, like, for example, the Mackenzie method, that addresses disc herniations. Now, you try to remobilize the body's muscles, and various approaches do this or attempt to do this in a way that spares irritating a painful, degenerative, or irritated part. I would definitely talk to your therapist in detail about whether the therapy exercises you're doing are indicated for your specific problem. And again, at the risk of sounding redundant, if you don't feel like you're getting proper, direct answers, get a second opinion. Our next question comes to us from Instagram, from Nathan. Doctor, can poor posture really have an adverse effect on your spine? I love this question, Nathan. So many patients come in blaming themselves and blaming their posture for their back pain. And the logic is actually in reverse. Your posture is a result of your skeletal structure. It's very difficult for you to artificially change your posture without leading to muscle fatigue and essentially a reversal back to your normal position. So my mom, when I was a kid, used to stick her thumb up my back so that I would sit up straight. But the reality is that science doesn't support sitting up straight as a way to maintain good posture. Now, there are exercises that will help you bring your shoulders back and chest out, which supports ideas of good shoulder motion and ease of breathing. But if you have poor posture and if you have pain, then the answer is to address your pain. And that means getting an MRI, seeing a specialist, and addressing the problem, either with an injection or, if you can't live with the pain despite injections, with physical therapy or surgery. I really appreciate all these questions today. And to our audience, as always, I just want to encourage you to seek a second opinion if you feel like your well-intentioned questions about your health are not being addressed. Until next time, thank you for visiting All Health TV. Ask the doc, no appointments needed.
Thank you for listening to the Health Channel podcast. We hope this information has been useful. However, please remember that only your doctor can advise you about what is best for you. Do not start, modify, or suspend treatment based on anything you have heard on this podcast. Please join us again soon.